On behalf of the Integrated Health and Wellbeing Council, I welcome all of you to yet another informative session in the Heart Health Awareness series, Get Smart with Your Heart. This is an initiative by the IHW Council and supported by Boehringer Ingelheim. In today's session, we'll be discussing about Ayushman Bharat and cardiovascular care, how government initiatives have made cardiovascular care a more accessible and affordable thing when it comes to the overall health of individuals. So let me take this opportunity to introduce our speakers for the session. May I please request Dr. Neerja and Dr. Sandeep to switch on their cameras? Thank you. So we have with us Dr. Sandeep Singh, who's Assistant Director, Directorate of Health Services, Punjab. Welcome to the discussion, Dr. Sandeep. And then we have Dr. Neeraj Bhalla, who's a Senior Director and Senior Consultant, Department of Cardiology, BLK Super Speciality Hospital. Welcome to the discussion, Dr. Neeraj. So coming to you, Dr. Sandeep, my first question would be to you. When we talk about accessible and affordable heart care in the country, how do you see the present scenario with so many, government initiatives working round the clock to ensure health equity and, with a focus on non-communicable diseases? Where do you see the heart health ecosystem right now?
Well, if I take you... First of all, it's a nice initiative. I congratulate you and your team, for taking this informative, workshop or consultations to the general public through other media on the social media. And let me first share with you the historical part of it. Like, up till 2000. All the health systems were working primarily, especially in the LMNs, ICs, on the communicable side of the things, or RM and CHA services. I hope you understand RM and CHAs and the communicable diseases, which we were focused on all the throughout. And as in the last few decades, there is a shift in the lifestyle, especially in the northern India, and of course throughout the world, also globally. But we are more concerned because the state I belong to, Punjab, there is a tremendous, lifestyle change because of the westernization of the living styles and prosperity, of course, which has been brought by the Green Revolution in the state. So the trend has shifted, globally from communicable to the non-communicable diseases. The overall burden of disease now is non-communicable. About 65% of the disease burden is about non-communicable disease. And about 70% of the mortality case we see, it is from the non-communicable.
NCTs, right, Dr. Sandeep. Meanwhile, we are also joined by Dr. K. Madan Gopal, who's an advisor with Public Health Administration Division, National Health Systems Resource Center. Welcome to the discussion, sir.
So, as I was sharing you, because in these NCDs, cardiovascular health issues are the main burden, which I'll say from all the burdens of NCDs. About 30% of their burden is from the cardiovascular health diseases. And root causes, all we know that it's the stress, it's diet and lifestyle. And one of the starting point is the hypertension, which is now, increasing, day by day. The prevalence of hypertension in the country is about 22 to 23%, while in Punjab we have approximately about 34% of the prevalence. So that means in my state, every third person is hypertensive. So this makes a big concern for us to take a challenge, and we have started many projects, like India Hypertension Control Initiative, which we are running in almost now 15 districts out of 23 in the state. And then we have a STEMI project, if I look at it that way, there are two bad outcomes from the uncontrolled hypertension. Either person will have a heart attack, or he'll have a stroke. So to tackle that side, like, we have a special STEMI project also in the state. We are running it presently in the 8 districts out of 23, and we are expanding it to all the districts. We have got the permission, and we'll be making the golden hour work. Like, we'll be thrombolizing the patients in the first hours, that we call golden hours, like, for ST elevated myocardial infarction. So this is the background, and how Ayushman Bharat has helped, because the program which we run, it's called now National Program for Prevention and Control of NCDs. Earlier it was called NPCDCS program. Under this program, we are doing what is called population-based screening at the ground. All the population above 30 years is screened for hypertension, and of course diabetes, and 3 common cancers also, overall NCDs. But if today we are talking for the heart, it's World Heart Day tomorrow. So population-based screening is happening along with what used to be sub-centers are now upgraded to what are called health and wellness centers. So out of the 2,952 sub-centers, we have converted 2,500 into health and wellness centers, where we have a special human resource called CHOs. So these community health officers are doing the screening. They're the better educated than our other multipurpose health workers. They're BSc nursing men, and then there are Ayush doctors recruited in that. So that is the ground, and then opportunistic screening also in all healthcare facilities. Like, we have, like, especially in my state, all district hospitals, all sub-divisional hospitals, they have what is called arm in blood pressure apparatus. The person has just put in his arm, and the reading comes, like, without, any physically you have to get things, so easy to do. Anyone who is moving around in the OPD waiting area can just put in his arm and get his BP checked. So this is, we are expanding it to now to the level of community health centers also in coming time. Maybe it's in the process, so we'll be expanding to the community health centers also. So
thank you, Dr. Sandeep.
Yeah.
Coming to Dr. K. Madan Gopal, sir, Dr. Sandeep has already pointed out how government schemes are working to ensure better cardiovascular care, and in fact, the whole NCD scenario is changing. So, when we talk about Ayushman Bharat, and what have been your overview of the whole scheme, and especially when it comes to NCDs and cardiovascular care in particular?
Dr. Bichit, this is a very pertinent question in the current scenario, when we would be observing the Health Heart Day tomorrow. That's one thing. When the scheme was launched, so you have seen the transition, how the healthcare and the health insurance scenario in the country has transformed over the last 1 decade. When the earlier form of this scheme, because many of the state governments in the southern part of the country, they have rolled it out as a insurance scheme. They called it Arogya Shri schemes and the Chief Minister Comprehensive Scheme, and the other names of the schemes were there. When the Rashtriya Swasthya Bima Yojana was launched, coverage was 30,000, and it was felt that we should be having a package which can cover the secondary and the tertiary level care, and the cardiac being one of them. As the incidence of hypertension and the diabetes, as we have put so much impetus in our revised strategy of comprehensive primary health care, wherein we are ensuring well-assured services from the peripheral most health institution, that is Health and Wellness Center. That is Ayushman Bharat Health and Wellness Center. That is one of the pillars of the Ayushman Bharat, one of the 4 pillars of the Ayushman Bharat. Because full focus is on screening. After the screening, you will be having people with hypertension, diabetes, and some of them, they require hospitalization. That's why, and if you look at the census data, the deprivation criteria, there are around 60 crore population who would be covered under this scheme, the PMJ scheme. That means these are the people who require services. Otherwise, if you look at the national consumption pattern on the expenditure, the people, it's around more than 70% of the population, they earn less than 40, they consume 40,000 rupees per month. A single episode of illness, they at least knock off their salary by 2 months. So that kind of thing, to give a protection, to empower these patients so that they can get themselves treated, to be required to increase the package. That was from 30,000. So first it was raised to 2 lakh. Then it was thought that 2 lakh is also less. Now we are having a package of 5 lakh rupees per family on a floater basis, which covers all all the ailments, including the cardiac ailments. So because even a single cardiac ailment that leads to catastrophe, and one of the important milestone which we have to achieve for attaining the universal health coverage, that means you have to reduce this catastrophe to less than 25%. Right now it is around 47-48% out-of-pocket expenses. It has to be brought down to 25%, less than 25%, as per the global norms. For doing that, such schemes are required. That's why even in a middle class, even if they are covered, if a single episode of this cardiac ailment is there, you see that how it is straining on the family expenses and other things. So to prevent that out-of-pocket expenses, the government has brought this scheme, Pradhan Mantri Jan Arogya Yojana, which is known as the ABPMJY. It provides a cashless, paperless, this assurance of 5 lakh rupees cover for this, in which around many of these cardiac procedures are covered. Apart from that, all procedures, if a person is sick and if it is not there in the procedure, the hospital can get a pre-authorization on that particular procedure and the patient can be treated in that hospital. That kind of provisions are there. The whole objective is to see that how the out-of-pocket expenses of the patients, which leads to catastrophe and the patient slips into the cycle of poverty, how it is averted. That's the whole objective of this scheme, and it has been evolving. And day by day, we are building capacity so that the uptake of this scheme is also increased. You see that recently, from 13th of September, I think our Honorable, our Excellency, President of the country, she has launched this Ayushman Bharat scheme, wherein we are trying to create awareness among the people regarding this Ayushman Bharat scheme, PMJ scheme. On 2nd of October, they would be having a Gram Sabha. In the Gram Sabha also, they would be listing out the list of beneficiaries who have made the card and who have availed the scheme benefit. That's why awareness drive is also going on. So besides this, the scheme is moving to a boom for the people. And if you look at how much expenditure has been prevented, you might have heard our Honorable Prime Minister saying that how much out-of-pocket expenses have been prevented by this scheme. It is at the tune of around 67,000 crores. Since the start of the scheme, we could at least prevent this pocket expenses of the poor people. That is around 60 crore people. We have been able to prevent that kind of expenditure from their pocket. But this expenditure has happened and the scheme has borne this expenditure.
Right, Dr. Gopal, you have very rightly, given us an overview of how PMJ has worked in ensuring accessible and affordable healthcare for the larger part of the population. Coming to you, Dr. Neeraj, how would your work as a cardiologist, and you're working amongst the masses, what is your overview when we talk about cardiovascular care, accessibility, and because you can have accessibility, affordability also, but at the same time, there has to be that level of awareness, where people know about what is happening. So what have been your experiences in that regard?
So let me thank my co-panelists, Dr. Madan Gopal and Dr. Sandeep Singh, who are both working with the government services and part of Ayushman or implementing these. So thank you very much for educating someone like me, because in our state of New Delhi, Ayushman is not operatable, does not operate. So, but I'm aware of this scheme. So, as a treating cardiologist at the receiving end of all the failed efforts of non-communicable disease prevention, we get these patients. So I will suggest 2 or 3 things that I think are very important. What we are trying to do with are either primary or secondary prevention and treatment of these things. But I will suggest that much more important, more impactful, and where the government can play a very important role is what is known as primordial prevention, whereby you see governments in most Western countries ran campaigns against tobacco, against the use of saturated fats, and many health initiatives, and they use legislation and they use the power of the government to create or change the trajectory of the development of these non-communicable diseases. This is something that our government seems to be lacking. Number one, I think we are trying to throw money at a problem, but we are not trying to solve the problem. So I think that is one aspect that can be also important part of the strategy for tackling NCDs. As Dr. Sandeep pointed out, this is a growing menace and this is the number one killer. And number one out of these NCDs is cardiovascular diseases. Secondly, I will say that in terms of all these schemes that are running, I think a very forensic audit should be done regarding. It's very good to see that how much has been saved and what has been done, but an audit is required as to how the funds are being utilized, how are the hospitals actually billing these patients, what is being done. In my knowledge and awareness, there is a lot of misuse of the funds by the hospital, beneficiary hospitals, and the poor innocent patients are being targeted. So I think very forensic audit as to the effectiveness of these funds being utilized and what are the pitfalls and all, so that the scheme can deliver actually on its objectives. We also know that offering very discounted services leads to use of equipments and use of many drugs, equipments which are not of a national or international desirable standard. So this is whether we are doing service or disservice to our patients also we need to understand. Understand that we are a country which is developing, or I don't know how we are now what we call as low middle income country. So we must pay attention to quality of care also being provided to our patients. Third aspect, I will say that strengthening of public health care I see that some governments are doing a lot of good job at primary and secondary primary healthcare level, where a lot of community health services are being provided, screening is being done, but there is a big problem in secondary and tertiary healthcare in terms of government hospitals being able to cater to the population at a desirable so this is the reason why private hospitals are flourishing. And that is because the patients have no option, and the private hospitals are also making a lot of profit. Maybe some of it is more than what is desired, but these are the gaps and lacuna in our public healthcare that I think we should also seriously look at. Certainly, in the absence of any other situation, a scheme like PMJ or Ayushman Healthcare is very desirable, so that at least the immediate problem is met and people's immediate burden, which can push them into poverty, is allayed. And the scheme, which is offering 5 lakh rupees as a family floater policy, is very, very welcome for vast majority of our population who can ill afford private healthcare and who are treated very poorly in public government hospitals simply because of lack of capacity of these hospitals to cater to the large number of patients.
Thank you, Dr. Neeraj, for that. Coming to you, sir.
So that's what I would, that would be my.
Thank you for that insight. Coming to you, Dr. Madan, Dr. Neeraj pointed out how there is a gap when it comes to proper implementation and, the challenges of availability of specialized healthcare personnel and, of course, capacity building. So what is the government, how is government ensuring that these gaps are addressed in a proactive manner?
One of the example of ensuring these gaps is that we are trying to recruit specialists on a mission mode basis. That means at the highest level also the message has been communicated that all the the government institution, wherever the district hospitals are lacking specialists, the specialist services should be there. Below the district hospital, we do have first referral units wherein the specialized services are available. That we are trying to fill in the gaps. We have trying to be very innovative in the HR aspect. That means some of the state government, they are gone to the extent of you quote, we pay. That means the government is giving a tender to the people saying that you have to quote the pay and you have, if you want to work here, and we will pay for that. That kind of thing. That's one thing. Second thing is, most of the district hospitals, they have been upgraded to medical colleges so that tertiary level cares are being made available at that level. Apart from that, you see how much focus is there on the National Medical Committee by the National Medical on increasing the specialist cadre or the specialist places in the specialist numbers. So much focus is there from both the routes, from the NMC route as well as the DNB route, because we are trying to see that the specialized services are being made available as near as possible to this. Another thing is all the district hospitals, they have been encouraged to start the DNB courses so that the specialist services in the form of residents as well as the they are made available at that place. Another initiative which have been taken for improving the specialist services is the district residency program, in which the senior residents, they are supposed to be placed in the district hospital for 3 months, so that a senior doctor or a near specialist doctor is available at the district level. These are the efforts which are being made to strengthen the district level services. Apart from that, at the CHC level also, that the community health center level also, we are trying to see that the specialists, that the medicine, obs-gynae, pediatrician, anesthetist, and the other surgeon, general surgeon, they are being made available. And some of the states, they are being partnering to the STEMI initiatives, how to salvage the patient as early as possible. Other thing which is also happening is creation of the emergency and the trauma care. That means that includes this cardiovascular accidents as well as the other problems associated with the catastrophe of non-communicability. That's also been considered. Any new medical college which has been opened, they would have essentially to have an emergency medical department, which will cater to all this emergency need on a tertiary basis. But from that, district hospitals and the other places, the centers are already coming up. That's one thing. I will just come back to another thing of what we are doing through PMJ. If you look at the bed strength in the country, there are around the last census which has happened, that has brought out that there are around 14 lakh beds in the country, of which around 6 lakhs beds are from the private institutions and the majority in the government sector. The 70% of the expenditure happens in the private sector on the tertiary level and other scale. But the footfalls in the government and the private is more or less equal. That kind of shift is happening because of better services in the public sector hospitals. As the other panelists have mentioned about the cost factor in the private sector. So that's why the 70% of GDP expenditure usually comes from the private sector. Only 1.2% comes from the government side. No issues. But the footfalls in the government system is increasing. The schemes like PMJ, as more and more efforts are being made to build capacities of the states and put more efforts for increasing the uptake of the scheme. If you look at the way the private sector has partnered with the government sector in providing the specialist services, especially the tertiary level services, you see that you would wonder that how the scheme is progressing. As I mentioned about the number of beds, how much only few of the big hospitals, they contribute to around 7 to 8% and bed strengths. But the maximum of the bed strength is scattered across the country. We have to see that how we utilize that thing, and PMJ is an example in which how we are bringing in the specialist care in the tertiary and the other places. If you look at the empanelment in PMJ, out of the 25,000 odd hospitals, more than 50% are private hospitals, and that too, many of them, they are tertiary hospitals, more than 100 bedded hospitals. That means the government is making efforts in seeing that how the tertiary care efforts their care is being made available to the people for which it is having a commitment to provide services. So that kind of efforts are already being going on. And wherever the MD, MS and other people are not there, we are trying to multi-skill that person, send him for training so that he can come back and treat the patients. Another innovative thing which has happened in the government sector is extension of the teleconsultation right up to the health and wellness centers. We have around 160 health and wellness centers, and all the government doctors who are there at the district and the sub-district level, they have to provide their specialist services to the health and wellness center. And the health and wellness centers are manned by a trained nurse. That is, BSc nursing is manning that nurse. As the doctor is giving instructions in his ward, so the same thing with all the things with the telemedicine, is communicating the notes and other things so that the treatment happens at that level also. In case of referral, we are having a referral transport system which picks up the patient and brings the patient to the hospital in case of emergency. We are trying to build in all the structures which can at least aid in having a high quality services being provided to the people as near as possible. We are moving in that direction.
Right, sir. Very rightly pointed out. Coming to you, Dr. Sandeep, Dr. Neeraj talked about some of the gaps in proper implementation of PMJ and other health schemes. So, what is your take? How are those gaps being addressed? And I would also want you to focus on how digitalization can play a big role in addressing those gaps. What is your take on that?
Well, first, I'll come to the gap parts, very rightly pointed by Dr. Neeraj about the frauds. I'll say not exactly the word, or misappropriation of the scheme, Ayushman Bharat and PMJ scheme by some of the private sector hospitals. So, as I see in my state, we have what is called an anti-fraud unit with this. This scheme runs under a special state health agency, which is manned by senior bureaucrats, and then they look into all the complaints which the panel hospitals they are there in the state for this scheme. Then I happen to be part of that, and of course, definitely there are mechanisms to make checks on the misutilization of the innocent people's card, for frauds and things like that. So there are units for anti-fraud units. Then coming to one important concern is about the drugs. Rightly said, Dr. Neeraj had said about sometimes substandard drugs. But I assure you, in public health, at least in my state, I have watched it. We have there is a proper Food Drug Administration, where all the drugs purchased under the special organ called PHSC, Punjab Health Systems Corporation, they do a quality check, and drugs are, which are provided under the system are quality monitored. Of course, then there is a larger portion, which is the local chemists, which though the FDA does do the checks. But I'll raise the flag where the manufacturer is. I think there need to be check at the level of the manufacturing units itself, where the drugs are being manufactured, who are the drugs which have low quality or don't provide the proper bioavailability of the medicine. So I think that's one area of concern where it should be. About the digitalization, yes, of course, all the NCDs now we have, there's a proper what you call CPHC NCD portal. We had in the state another independent portals also running, like for IHCI, we had something called Simple Lab. The name suggested Simple Lab. It was very helpful in the initiation of this program and got good result. But we have, because a lot of at the ground, in the health and wellness center or in the sub center, we have the same one person, multi-purpose health worker or a CHO doing multiple programs. So they have to punch into different portals. So at least for NCD, there should be one portal, and which the government did listen to me. Fortunately, I was the one advocating it, that this should be, there should be integration of portals. And I'm sure that Dr. Madan at NHRC will vote for it, that the exercise is already started to integrate all the portals, in the healthcare, so that is going on. And digitalization is definitely helping in controlling the NCDs. We have follow-up mechanism. We can see on the portal, which patients are hypertensive and on medication, and the local healthcare staff, they follow them, like ASHA and this CHO. So it's a boon for the IT, is a boon for the NCDs and NCDs management.
Dr. Sandeep. Dr. Neeraj, coming to you, when we focus on cardiovascular care, and in the start of the discussion, you talked about how tobacco use, and there are certain, risk factors for. So when we talk about a preventive lifestyle with a focus on heart health, how do you think, what are some of the measures, how, that move from towards a preventive lifestyle can be initiated? What is your take on that?
So this is not rocket science. In India is world capital in diabetes, hypertension, and heart disease. Also, so I think we need to have, like I said, very, very important, what is known as primordial prevention, because many of these practices are socio-cultural. And socio-cultural practices are ingrained in us through our upbringing, through it comes from where we are born, what are the resources that are available, how our lifestyle has developed, and become very difficult to change these kind of things. So, being the spice capital of the world, we are used to having our foods which are really deeply cooked, and where we add all these masalas, and our palate has become used to it. Now, the sad part, or the price that we have to pay, is that this leads to much more development of atherosclerotic cardiovascular disease. In earlier years, then there is a theory that is known as that the starvation gene theory, whereby because we were subject to earlier many famines and all, so the body developed a mechanism by which it would store fat. So we developed a kind of, apple-shaped obesity, which again made us prone to. So these are some, real issues that are there with us for decades. And to turn this trajectory around is not easy. Also, as we know, what food we consume is, again, it's in the families. It's similarly what lifestyle in terms of exercise or in terms of awareness of that is, again, it comes to you not naturally. It has to be cultivated or be in the family. And whereas we see a shift in the more educated class towards a more healthy lifestyle, the burden of cardiovascular disease is in the lower and lower class of people who have got very poor access to good quality nutrition, who are so concerned about meeting two ends, that they have little time for healthful practices. They are the ones who are exposed to maximum air pollution. They live in crowded areas, so they have got much more, incidence of both, say, rheumatic heart disease or so many other conditions. So these are tobacco use, for example. So these are the, real issues which require deep thinking. As far as I am concerned, or as far as, as medical people, I think all of us are doctors here. Medical people are concerned, I think the National Hypertension Control Initiative of the Government of India is very good. So wide publicity should be given as to what are the correct targets, what should our blood pressure be, give people specific targets, that if your blood pressure more than 140/90, you are at higher risk of developing heart disease or so clear messages and on a wide social platform. As far as, so these are the preventive healthcare. So as in my hospital, I see most of us run, and all government officers, I'm sure both these doctors, undergo periodic medical checkups as part of the process that central and state government follow for their employees. Something like that can be introduced maybe in a scheme like PMJY, which may lead to even better savings in the long term, if not in the short term. That you pay a hospital a certain amount from PMJY that to do a preventive health screening, which will carry out these few things. So that may set the patient on a trajectory where he or she can treat the diabetes early, treat the hypertension early, treat the cholesterol early, so that they never develop or don't have to pay, or nor does PMJY have to pay high expenses for treatment. And as we know, treatment of cardiovascular disease is a very low return game. By the time the patient has suffered from this, there's a lot of expenses. It's not an infection. The disease never really goes away. So, you can start doing all these preventive things much earlier in the cycle. So primordial prevention, preventive screening, periodic medical checkups at all levels, and of course, opportunistic screening, like Dr. Sandeep said, that at whichever opportunity we get, check the blood pressure, check the blood sugar. So these are the various strategies. It's not rocket science, but it needs to be thought through and implemented. And unfortunately, we tend to think of benefit in short term or very short, medium term. We must invest in long term so that the benefit will also accrue and the cumulative benefit can be massive for our health.
Right, Dr. Neeraj. Dr. Madan, sir, coming back to you, how is government ensuring that we integrate primary, screening for that preventive, to include that preventive approach in the whole ecosystem when it comes to NCD management with a focus on cardiovascular care?
As I mentioned earlier, I just mentioned about the health and wellness centers. If you look at that, as we have moved, I have to give a little context to this. We have moved from disease-oriented strategy to health strategy. From health, we have moved to wellness, and from wellness, now we are focusing on the well-being of a person. So to address this issue, initially we had adopted the primary healthcare approach. Now we have revised the strategy, and now we are calling it as a comprehensive primary healthcare approach. Previously, we were ensuring 6 assured services through our health centers. Now we are assuring 12 services through the health centers. Having said this, now you have to appreciate the structure of the public health institution. At the village level, you are having your volunteers who are known as village health, who are known as community health volunteers or the ASHA workers. And for 5-6 villages, we are having a center. Previously, we used to have a sub-health center, which used to cater to a population of 3,000 to 5,000 population, depending on the terrain and the areas, which is usually been one health personnel is there, who is known as female health work personnel or the female health worker, depending on the nomenclature which the state is using. But essentially, in the common parley, we call them ANMs. They are responsible for 5 to 6 villages, essentially 3,000 to 5,000 population. That means at the village level, you are having a person or volunteers. She is a woman, married woman, and living in that woman, and she has undergone around a number of trainings. 13 round, 14 round trainings have happened. It's not a single training. So that trained person is there who can mobilize the community and bring them to the institution. At the institution, previously it was sub-health center, which was headed by your health worker, male and female. Now that sub-center had, and from the sub-center, we were providing 6 set of services. 5-6 sub-centers at the level of sector, that means which caters to 5-6 sub-centers, is a primary health center, which caters to a population of 20,000, 30,000. Here comes the community comes in contact with a medical officer. Above that is a block, and block above district and the other 3, everybody knows that. But these are the peripheral most units which most of the people are not aware about. From this peripheral most unit, the sub-health center which I mentioned, these have now been upgraded as health and wellness centers, which are providing 12 assured services. One of the assured service is screening of the population for hypertension, diabetes, as well as your cancers, that is breast cancer, lung cancer, and cervical cancer. So these are the three. Based on cancer screening is usually on a symptom-based feedback form is there. But anybody walking into this health and wellness center, they are essentially screened for blood pressure and their blood sugar levels are monitored. And after that, based on the consultations and the prescription given by medical officer, a treatment is being given. That is all free of cost. This in the essential medicine list, which needs to be available at the BSc, CSC, and this health and wellness center level, the hypertension medicines are there. So this is essentially happening. And if you look at the NCD portal, they will give you the number of this. As a second step, what we are ensuring is that the continuation of the treatment is very important. Once you have detected the person to be diabetic or person having hypertension, the continuation. On a regularity basis, the medicine supplies have been ensured that this person receives their supplies on a continual basis. Whenever some requirement is required, they can always talk to use the telemedicine facility. Sanjeevani is there. They can use that thing. In case of some consultation is required, they can go there. And if they fall into this PMJ bracket, they can always be referred to any of the PMJ hospital for availing services. That kind of mechanism is there. If you look at the portal, the exact number I am not knowing, but you can refer the portal and you can get the exact numbers from the portal that how this program is able to screen the people as well as bring in awareness about this hypertension and diabetes. We are not restricting ourselves to here only. After screening, provision of medicine, which I have told, and apart from that, lifestyle modification is also being, we are trying to implement that. That's why we are calling them as health and wellness centers. Health aspects we have covered. Now we are covering the wellness aspect. That means at these institutions, we are holding the wellness camps for the village and the villagers. And the trained yoga instructor is coming on a weekly basis or a daily basis, whatever the institution feels like. They usually hold camps at this wellness centers so that the lifestyle modification can also happen. That means we are taking care of the health, we are taking care of the wellness aspect, and we are trying to move towards well-being of the person. And whole effort is now going on. But besides this, the government is also trying to address the social determinants of this. You might have seen the Eat Health campaign, you have seen the Fit India movements, you have seen many other determinants, that is Swachhata Abhiyan, and the other Abhiyans are also there. They are hitting the social determinants of health. That means social determinants have been taken care, the health is being taken care, the wellness of the person is taken care, as well as we are seeing that the person is moving towards being a well-being person.
Right, Dr. Madan, thanks for that insight. So we are already running out of time, but Dr. Sandeep, I would just come back to you for the last question. Any major takeaway that you would want to talk about when it comes to cardiovascular health and Ayushman Bharat, government schemes, accessibility, affordability for the larger population?
Yeah, thank you. The two things, I'd like to definitely emphasize on, like Dr. Neeraj has mentioned about the preventive side. We are working on that, There are a lot of things which can be done, and we have learned a lot of things which, in fact, the lessons are learned from the West once they have completed that, tragedy, So, like for the cancer, like for the hypertension, they changed their lifestyles. They reduced the salt intake. They created what they call salad bars in their markets, for population. So we need to look into how we can change the behavior of the public. Social media is very important now. Every kid has got a mobile phone in his hand. So social media can play a lot of big role, as well as the media as such. I like to emphasize is we have some channels, which regularly gives such talks, like we are having this consultation with the experts, and these channels on the television, all channels should be made, it should be mandatory for them, what you call social corporate responsibility mechanism for them to broadcast free of cost these such health programs, for the awareness of the public. So this can be taken up by the government of India, that this CSR sort of modality is created for giving a license to them to broadcast. Then I'll also like to emphasize, that for Food and Drug Administration. We have a SAI, at the Government of India, which can just 1 gram of reduction of salt can bring in, I think, we have a senior cardiologist with Dr. Dheeraj, I'm not mistaken, I think 4 or 5 mm of mercury reduction in blood pressure, with 1 gram reduction in salt intake. So ideally, it is advocated 5 grams of salt, per day. But if we make awareness that at least we cannot stop immediately, you reduce your salt intake. This will reduce the blood pressure, which is the root of all the heart diseases, major heart diseases, one of the main cause of the cardiac problem, which is hypertension. So this is one thing very important I like to share. Then, of course, the role of, we should have a multi-sectoral approach with all the other ministries and departments involved, for NCDs as such and for cardiovascular health. We are now so much, what we call physically inactive. People, even youngsters, are not playing. We have to push them out to go and play. Where it was a time when parents used to get us back from the outside to home, like, in the evening they would, like, the kid is back. So this physical activity needs to be increased, way of one, what are called happy streets. So the traffic is, controlled in the morning hours so that people can walk on the roads, free of any risk, from the traffic. So such measures, we can pilot. I was planning in my state to pilot such things, in few major cities. This can be, I think, at the highest pedestal at the Government of India. We can learn from the other states, best practices, and incorporate, down and to all that. So these are my last words. I think session can be very long than discussing NCDs, So thank you very much.
Right, we can go on and on, but time has its own constraints. I would just take this opportunity to thank Dr. Sandeep, Dr. Madan, and Dr. Neeraj for being here with us, taking out time from their busy schedules and helping us in this awareness creation activity. Like Dr. Sandeep said, and awareness does play an important role. And thanks for joining us. And we hope that government initiatives like PMJ keep on playing a very active role in this stride towards a healthier India, where the holistic well-being of, health of individuals is prioritized over anything else. Thanks for being with us.